We have a very exciting topic today for all of us, and it's food as medicine. I had fun coming up with this title. I definitely used AI to help out, but the latest scoop on policy evidence and how to choose the right partner is what we'll talk about today. And for me, the conversation today is really about a broader shift in healthcare that I've been noticing, and specifically nutrition moving away from kind of more of a public health intervention to specifically a managed care benefit that can help manage costs and outcomes. And so that will be the main focus of the presentation today. All right, so who am I and why am I qualified to talk about this topic, right? The lens that I bring to the table today is really that of managed care. I spend the majority of my career in managed care, working in strategy and business development. I've worked in a variety of capacities, but the main idea has always been, how do I help managed care evolve the definition of benefits and really understand what payers need in order to evaluate, adopt, pay for, and scale various interventions, with nutrition being a key focus of the work that I've been doing in my career. I helped develop and scale a national diabetes strategy for over 300 members that we had with type 2 diabetes, and that included thinking through CGM reimbursement, food access reimbursement, and various other population health interventions. Part of that work also involved co-leading our Medicaid population health strategy and health equity strategy across over 20 states. And a lot of that had to do with supporting the build of a strategy that is standardized enough at the national level, but also flexible enough at the local level so that it would resonate with the members that we're serving. So a lot of the experience that I will talk about would be rooted in my actual work in managed care. And today I'm joined by another fantastic leader who, by the way, just won the Women in Business Leader Award. So Leah, tell us about you.
You didn't tell me you were going to say that.
Right. I had to.
Yeah. My name's Leah Aber-Wells. I'm the CEO of Open Arms of Minnesota. And we'll talk a little bit more in a minute about what Open Arms is. But I got here in 2013. And so I've seen a few things. We've grown a little bit. One of the ways that we've grown is through some interesting contracting opportunities. We've increased in size from about a $2 million organization when I got here to almost right around a $14 or $15 million organization now, and it's about partnerships, and some of those partnerships are with healthcare, some of those partnerships are with the government, but it's really about figuring out how to get people meals and have that be a great partnership for both the client or patient and for the partner organization. So I also sit on the advisory board for the Food as Medicine Coalition, which is the national coalition of medically tailored meal providers and medically tailored grocery providers. And I've been sitting on that coalition since I started, and we've really evolved as well and have been working on food as medicine as a concept and medically tailored meal guidelines for the past 13 years or longer. All of those organizations are similar in scope, and that we provide critically ill folks with pretty serious health conditions, home delivered medically tailored meals based on their nutritional needs. So I also oversee the operations committee and all of our subcommittees. So we're really working on things like standards for medically tailored meal programs.
I'm really excited about the perspective Leah brings, because it's that of the operator, right? How do we actually fulfill and what does it take to deliver medically tailored meals and build sustainable funding models and really support holistically high-risk members? All right, so we're going to dive right in. So the objectives for today are for me to move to three key questions. First, what is changing in policy? Second, why does that matter for managed care? And then third, how should managed care really evaluate different providers of nutrition solutions? What are the things that they need to look for? And I think the sequence is important because policy alone does not create impact. We need managed care to translate policy into practical operating models, and often that happens through vendor partnerships. And so I hope you enjoy this. And again, this is meant to be interactive, so if you have any questions, please feel free to tune in the chat. So you probably all know this. We decided we're going to assume kind of a foundational level of knowledge. Most of you work for vendors. Most of you work for the state and are managed care and are purchasers or partners of these type of services. So we're assuming kind of baseline understanding of nutrition solutions here. What I did want to call out here is that, again, in the opening, as I mentioned, nutrition used to sit mostly outside of healthcare, and specifically the healthcare financing system. And you'll see, I'll do a deeper dive into kind of the main changes that have happened that have now started to integrate what was once considered social care services into the formalized system. And now we've got billable and ways to reimburse for this. We've got coding available, in some states even more advanced than what we see nationally. And so I want to talk about some of these key mechanisms that are now being used to deploy this at a national scale. But the kind of where we are today in the next phase in my mind will really be defined by which nutrition interventions can prove clinical impact, that can prove reduced utilization of healthcare services, that can scale operationally, and that will neatly fit into the formal benefit and claims infrastructure. So that will be the focus of today's conversation. Actually, Leah, any thoughts on this evolution that you wanted to add?
I mean, I think as I mentioned in 2013, when I got to Open Arms, we were already doing many of the things that are in here. We were already doing work with registered dietitians and medical nutrition therapy. We were already doing medically tailored meals, but nobody was having those conversations with us. And there wasn't even a national dialogue. And over the past, especially the last 5 to 6 years, the national dialogue around food as medicine has absolutely accelerated and has started to include community-based organizations like Open Arms and some of the, I think, folks on this call who are doing the work and helping set the standards even for the last 30 years. So it's an exciting evolution for all of us.
Awesome. So before we get into all the specific proposals, I did want to preface this by saying that we're not saying that every bill that we'll talk about right now is going to pass. But what I do want you to notice is how the conversation has changed. The proposals that we're going to look at are now being introduced really focus on clinical validation. They focus on nutrition, the innovative payment models. They focus on measuring outcomes. And so it's a very different conversation than what I've witnessed in kind of the prior decades that were simply focused on food access. So Leah, why don't you kick us off? Because I know this is very near and dear to your heart and you've been working hard on it.
Yeah, so the Food as Medicine Coalition has been working with some representatives, particularly Representative McGovern out on the East Coast, and putting together this pilot that we introduced in 2024, have been working to get Senate and House support for. But the exciting thing about it is that it sets some standards for what a program would look like, and then ultimately, as a pilot with a partnership between local hospitals and medically tailored meal providers like Open Arms, we can find results. And that's really what we're looking for, is to illustrate the difference that medically tailored meals can make with seniors specifically who have diet-related diseases like heart disease, diabetes, and COPD, which is what we all want, is to show the results and see what kind of an impact medically tailored meals would have. So we're excited. There is some momentum behind this bill, and it looks like some bipartisan, bicameral momentum. And so we're hopeful that we will make some changes here.
Awesome. And for me, again, coming from that managed care perspective, This matters because it frames medically tailored meals as a healthcare intervention that can be tested against outcomes that plans already care about. And so when I think about managed care, especially MA plans and dual focus plans, as when this passes, medically tailored meals, can become a critical part of clinically legitimized intervention that is outcomes tested. And so I'm really excited about this one. The following one, this proposal is a really good example of where kind of the market is going. Food benefits are being discussed to be included inside bundled payments and accountable care models. And for me, coming from a financial background, I'm specifically excited about when I see kind of new payment models for these type of interventions, because incentives is what really moves the space. If we have the right incentives and the right payment models in place, that enables delivery of benefits that may traditionally not be accessible. So this was the key piece here for me in the Accountable Produces Medicine Act. How about the Medical Nutrition Therapy Act? Any thoughts on this one, Leah?
Yeah, I mean, I think this one is really exciting because it recognizes the importance of medical nutrition therapy and work with a registered dietitian in context with medically tailored meals and other nutrition interventions. So at Open Arms, we've always operated under the belief that pairing medical nutrition therapy with the meals is the most impactful. And then this bill would also expand who can refer and who is involved in that process. And so I think all in all, these are really exciting developments, and to Demi's point, really reflect a change in the narrative and a growing recognition that it's really the registered nutrition person, the person who's a registered nutritionist, who is really key in a success of nutrition interventions.
Yeah, I think pushing beyond the narrow physician referral pathway is really powerful. And so being able to integrate nutrition into and leverage other types of clinicians in the process can be really powerful and can really help scale this type of work. And then for Food for Health Act, to me, this act is important because it connects food as medicine funding to reporting around efficiency, patient outcomes, system costs. And again, for managed care to be able to facilitate coding, payment, reimbursement for services reporting is critical, a critical component of that. And then the other piece of this that stood out to me is that this is not just focused on activity. So it's not about just meals delivered or boxes distributed, but really it's about the impact that's being made. When I was at United, one of the programs that we ran during the pandemic was very much distributing food and meals to members with food insecurity and certain A1C metrics. And when we looked at the data, what we saw was a lack of improvement in certain parameters. And so when we dug further into it, what we realized is that a lot of the members that were receiving those meals would actually provide those meals to a family member, someone elderly in the home, or their kids. And so they weren't actually the one benefiting from the intervention. And so an important thing to consider here is when delivering these type of benefits, making sure that the whole household is considered, not just the individual as part of the intervention. And we'll talk a little bit more about this as we dive in. So these were the four kind of core policy proposals we wanted to talk through. And again, this shows you the spectrum of where we're pushing the boundaries and what potentially can come down the pipeline. But again, what's key for me is, again, being able to expand the type of clinicians that would provide the service and make the benefit more available and scalable. The fact that we're rethinking payment models when it comes to nutrition and structuring the right incentives so we can get the right intervention to the right folks. And then really continuing on with the clinical validation and cost effectiveness validation around readmissions, outcomes of these type of interventions. And yeah, any thoughts on this, Leah, overall?
I think you covered it.
I think it's encouraging. We're very excited. Yeah. All right. So with that, now that we've looked at the national landscape, I think when I think about federal policy, I think about it as that's where the conversation gets started. And then when I think operationalizing this is I like to look at the states and what they're doing, because this is where eligibility, managed care contracts, referral infrastructure, coding, a lot of reporting, a lot of those components become real. So we wanted to highlight a few different states. Most notably California. And I know we've been very inspired by the work that's happening there. So I'm curious what you think about California and what they're doing.
Yeah, so I mean, California is pretty well advanced in this process. They have a network of medically tailored meal providers throughout the state that are working CalFIMIC, they call it, and the coalition is contracted to provide medically tailored meals to the group of folks identified by the state as the highest risk. And they have successfully implemented this. It was really driven by FIMIC organizations, so Food is Medicine Coalition organizations that are medically tailored meal providers. The same can be said for Massachusetts and New York, that my partners in those states really drove these proposals and made this progress. And one of the pieces of success in these programs is that the medically tailored meal providers have to be accredited by the Food is Medicine Coalition through this very rigorous set of accreditation standards. And so we'll talk more about that too, but they've really, I think the success of these three in particular have standards that they have to, that they have to go by in order to really show progress and really be very, very rigorous in the medically tailored meal field.
For me, I would add to that, California is really inspiring me because they really give managed care a blueprint to pay for medically appropriate, cost-effective alternatives to institutional interventions in care, and instead kind of move into more preventable care that would help avoid, minimize avoidable ER visits, admissions, skilled nursing home stays, and so that to me is really, really key. I would also say I love what Wisconsin is doing because now Medicaid HMOs can reimburse Medicaid enrolled food as medicine providers for delivering medically tailored meals for specific high-risk members. And so being here in the Midwest, I think that's a really great move. The main takeaway for me from all of these leading states is that they're not creating kind of broad food benefits for everyone. Rather, the key that I'm noticing is really creating targeted nutrition pathways for high-risk members. So that is, we're probably only gonna see continuous innovation with that focus in mind. And then where the rubber meets the road in coding, this is the infrastructure. I love that these states are saying we're not satisfied with the outdated coding system that does not meet the ability to serve our populations well. And so they're putting the coding, they're putting the mechanisms in place to reimburse for these type of services. And this is, coding is a key way to scale these type of services, right? And so the better we can identify, document, refer, authorize, code, the better we can track and report and measure outcomes and impact, and therefore get reimbursement for these types of services. So kudos to the states that are really leading this in the forefront as well. Leah, anything you wanted to call out here? All right. So what we're seeing from the states at a high level, I would say, is that nutrition benefits are becoming more defined. Eligibility is increasingly tied to clinical risk, such as like pregnancy, postpartum status, post-discharge, functional limitations. And so vendors are no longer just being asked to deliver a service, but they're actually being asked to deliver, document, report, improve outcomes. And so that is where managed care organizations really need a partner strategy of how do I know this is the right vendor for me, not just a food benefit strategy. And we'll expand on that in a bit. All right, so far we've talked about the federal policy, then the state infrastructure changes, and now I would love to expand a little bit on managed care. So what does that mean for managed care? What should they do now to set themselves up for success? Because policy is opening up new pathways. All the coding changes is opening up new pathways. And at the same time, we've been very closely listening to all of the earnings calls, at least at the public and national payers, and then tracking a lot of the local and regional payers partnerships and kind of plans. And they're under intense economic and operational pressure. So if I were to summarize what we heard in earnings calls, managed care, as a vendor and as a partner and someone who's worked on both sides of the equation, you have to be very, very familiar with like what are they going through, so you can put yourself in their shoes and then be able to design a meaningful program and intervention. The main challenges that we hear over and over again is medical cost trend and utilization pressure. And I really see medically tailored meals and a lot of these interventions that we'll talk about as a key lever that can help in the reduction of some of these trends. Same with margins. We know they're tight. And a lot of that has to do with just general economic realities, right? We have a lot of people struggling because of the inflation that's going on. We have a lot of folks also from a public health perspective, increasingly being comorbid and higher acuity. And we've seen all kinds of innovations kind of pop in recent years. One of the ones that I cannot ignore and have to mention is GLP-1s. But when we look at the data for GLP-1s, is that they're adding a significant amount of cost to the economics of the treatment and total cost of care. Just in a few short years, the total gross spending on GLP-1s has gone from 1 to 9 billion. And so that's something to consider, is that not all innovations in healthcare are cost reducive, but rather accretive. And so we have to be mindful about how we think about what interventions we deploy in the market. And so one thing that I've been working on over the years, and historically, I would say that managed care has really looked into nutrition or has perceived nutrition into very siloed spaces and has seen social determinants of health and clinical medical needs as separate worlds. And a lot of this has to do with design and administration of benefits. And one quote that I love to go to is that we all will get the results that we design the system to give us, right? And so it's just an unfortunate reality of how payers were designed to begin with. And so on one side, trying to tackle social determinants of health needs through investments from their foundations, and then on the other side, financing bariatric surgery, specialty clinical care, GLP-1s through coding, etc. This separation makes sense administratively, I guess is my core point. It doesn't reflect, though, how high-risk members experience need. A member with CHF, diabetes, food insecurity, limited mobility and a recent hospitalization rate will not experience these as separate issues. They will experience them holistically. And so there needs to be a new way of thinking, financing, administering benefits that considers all of this. I was very fortunate to work under Dr. Cha, and one of the main innovations that he worked on was launching this idea of a care pathway, which is a way to address a condition or episode that a member is going through by looking at it from beginning to end and looking at the patient and their care journey holistically, rather than breaking it up into pieces. And at United Healthcare, we had various care pathways that we designed, including diabetic care pathways, maternal care pathways, substance use disorder pathways. And so that is something that continues to deliver results today. Now, before we dive into more of this new model, I did want to keep us honest and say that we're still largely not where we need to be. The solutions in the market are still largely point solutions, and they're solving for just one isolated aspect of a very large problem. So food pantries, grocery carts can solve the access problem. Social care platforms solve the awareness and navigation problem. Obesity, metabolic programs solve a scalable chronic disease management problem. So, but we have yet to see, who's going to solve everything holistically. And I would argue that managed care can really be that platform that unlocks the coordination and facilitation of a multi-pronged response to patients. And I have started to notice an evolution again, we mentioned some specific state initiatives around coding, and so expanding that coding and coverage. But then I would also say what I have seen is payers and employers going beyond the existing system, forging partnerships, launching pilots to really enable and introduce this type of innovation to their memberships. And so I'm very encouraged by the actions and the movements that I'm seeing. Now, I do think there's still a big opportunity, and that is really in the middle of, again, members who require not just a solution for social determinants of health, not just for clinical medical needs, but really at that intersection of if I cannot reliably shop, cook, or prepare the right food, and I have these SDOH and clinical needs, I really need a different type of intervention. And food as medicine is really positioned at the core of that. Leah, I'm curious to hear what you think about that.
Well, this is the whole reason why, an organization like Open Arms exists, is because we really look at our patient population or our intervention as the sickest of the sick. So often the most expensive folks, the folks who have the most illnesses, the most comorbidities, life situations that are very, very difficult, coupled with food insecurity and coupled with some of those other social determinant of health realities. And so where those two meet is a perfect, that's a perfect space for an organization like Open Arms to operate in, because we look at serving clients not just from a nutritional perspective, but really the whole client, making sure that they have stable housing, making sure that they are, not in an abusive relationship. We have client advocates who take care of all kinds of different social determinants of health while still providing them the kinds of meals that they need in order to have an effective health intervention.
Mm-hmm. And so I've been in Minnesota for almost 2 decades now, and I'm really passionate about our local system here. And I'm really inspired by what local payers are already doing. It's a ton of meaningful work around produce benefits, post-discharge meals, food equity grants. And yet I do think that we're in a point where we can move beyond just death by pilot, as I like to say, into larger scale programs. And we have an opportunity to really solidify the infrastructure for these type of interventions. And so what I'm, asking for is really a more disciplined nutrition risk strategy in partnership with whoever vendor you choose to work with, but really helping hone in who qualifies, which intervention is the correct one for which member. Really thinking through how is it delivered, how is it documented, what outcomes it changes, and how it's being measured. And so one of the best ways to do that is really find a partner who has been there, done that, who is willing to work with you with value-based care payment models in mind, who has the reporting and tracking capabilities. And I would also add that has that personal connection with the people that are being served. That is one thing that you can never really scale. You have to be able to have that personal connection. You have to have that cultural customization to really drive that adherence to treatment. And so from that perspective, and in my experience in deploying multiple pilots with multiple partners on all ends of the spectrum, really is that, again, not every member needs the same solution. And for members with chronic disease or post-discharge risk, the key question is, can the member actually shop, cook, prepare, follow the diet that the care team recommends? And if the answer is no, that is when you've got that intersection between food insecurity, functional limitations, but then the clinical need. And so medically tailored meals is really the best intervention for that type of member. And I would love to hear how Open Arms really serves those members. So Leah takes away.
Absolutely. All right. So Open Arms, as I talked about a little bit before, right now we are a multi-site operation. So we have 2 commercial kitchens. That is one thing that makes us a little bit different, is that we're producing all of our own meals. We make them all from scratch in-house. We've got 40 years of experience doing that. And for the past 20 to 25 years, those meals have been medically tailored, which for us has always meant looking at the clients with certain diseases that we can serve, creating menus by our registered dietitians to meet the needs of those populations, and then implementing a whole person strategy around those clients. So we, just like many in the space, have really evolved from a hunger-based organization to a nutrition-based organization over the life of our organization, which is, like I said, we're celebrating our 40th anniversary this year, so it's quite a milestone. We were built from an organization that was really about community care, as I told you, or as I mentioned before, that was really a hunger-based organization trying to solve the needs of our patients who had AIDS, who nobody else would help. So we were bringing them calorie dense, very, very buttery, cheesy, very dense meals to try and give them the energy that they needed to fight an active AIDS diagnosis. So that's how we started. And because of that, we evolved. I think we kept that sort of kernel of food can be medicine for folks. We kept that and that expanded over the next 40 years to really look at the food as medicine model and serve folks beyond just clients who have AIDS. And so our primary clients now have cardiac issues, ESRD, ALS, MS, and cancer. Oh, perfect. You're going to just skip right ahead. I skipped us ahead. But as you can see, we still have that core, that HIV AIDS group, but the majority of the rest of our clients have other diagnoses. And so we have developed menus that work for each of these populations. And with mostly cardiac being the largest. Our clients are, like we talked about, are really the sickest of the sick. And so they tend to be folks that can't shop and cook for themselves. These are the top comorbidities. Obviously, a lot of these go right along with those cardiac issues we talked about earlier. Mental illness also really speaks to some of the social determinants of health that we're helping, and sort of at that that area of overlap with people who are super high need and super sick. And so again, we work with lots of different food organizations who might be a better fit for a healthier client, and we refer to them, they refer to us. But for us, we really are looking at that population of folks who need medically tailored meals instead of other food interventions. So Our standard menu that we do at Open Arms is heart healthy. So everybody gets a heart healthy menu. And then, which means that each of these menus is also heart healthy. So we start with a heart healthy menu, perfect for people. It's it's a DASH menu, perfect for any folks who've got cardiac issues. And then we have a variety, obviously, of other menus. We have some new culturally familiar offerings that were developed in concert with the lived community and folks submitting recipes and then us being able to make those medically tailored. And so really our philosophy is we're not going to give people food that they won't eat, right? So it doesn't do a lot of good to give people food that isn't comforting or appropriate for them. And so we're doing our very best to try and modify our menus so that people will eat them and that will enjoy them, because that's part of what keeps people adherent on a specific diet, is to enjoy the food, to have it be culturally familiar, and to want to eat it. So we put a lot of time and energy into that. We do other things that help with adherence. And so we provide birthday cakes on folks' birthday. We can provide extra protein calorie packs, some nausea care packs that we put together, especially for folks who are in cancer treatments. So all in all, we look at the whole thing as a package with the client services and with the work with the registered dietitians, that all of this helps this be the most effective health intervention that it can be, and really accompanies that medically tailored meal process as well.
Just to add on that, and again, in my experience, the more personalized our programs were, the more effective they were. The better adherence we got, the better satisfaction we received. And so building that relationship with the client, and Leah, you guys also do delivery. And so a lot of the time, the volunteers and the folks that are receiving the meals build relationships. That's a huge component of them participating and sticking to and adhering to the program as well.
For sure. So this just shows a sample menu for our heart healthy diet. One of the really great things about the Open Arms menu is that we're trying to not just get people familiar food that they find comforting, food that they know, but also fresh food. And so you can see here our current delivery area, although we can work to extend and go outside of this delivery area, but our sort of standard delivery area is below. The two bubbles represent our 2 locations, which is allowing us all the time to add more and more delivery area. But one of the things when you look at the menu that we're the most proud of is that we are offering our home delivered clients fresh fruit, green salad, and a sandwich made that morning. So it's not just frozen meals. They're able to choose what sounds good to them at that moment, and whether it's their treatments are affecting their appetite, or if they have a lot of energy to eat or not. So they have a real choice between frozen and fresh items. Another big differentiator for us is the level of involvement of our registered dietitians. So, most food programs and most meal programs have menus that are developed in concert with a registered dietitian. Our client services program is heavily involves a registered dietitian. So, the initial assessment that every client has is developed by a registered dietitian. But those FIMIC accreditation guidelines that we'll talk about shortly here, they require us to offer every single client a session with a registered dietitian. Clients actually have to opt out of that, and they may opt out because they don't have the energy or because they have another registered dietitian that they're working with. But we are offering every client a live work with a registered dietitian with an assessment, and then potentially medically tailored MNT after that with registered dietitians. It's free to clients. It's included in their programming because of that philosophy we talked about before, where we really believe and have evidence to support that meals are most effective when they are accompanied by work with a registered dietitian. We screen all of our clients for malnutrition. we know that surgery and other interventions are not effective and are the least effective when somebody comes in with a high malnutrition score. And so one of the things that we're working with our healthcare partners is trying to get people in a great space in order to have further medical interventions. And so many of our clients come in with malnutrition. We work with them for a set amount of time and are able to really reduce that risk of malnutrition and have really positive score. You can see positive percentages of success there.
One of the things I wanted to add here is, and this was like a big battle for me when I was at United, was understanding that both undernutrition and overnutrition are rooted in malnutrition. And both obesity and like losing weight are actually rooted in malnutrition. And so again, this is affecting folks across the whole spectrum when we look at the malnutrition score. So it's a critical metric.
Yep, for sure. So let's talk about a little bit about that accreditation, because one of the things, because this is such a new field, there aren't a lot of standards as they exist out there. What is a medically tailored meal? What is food as medicine? And so, which there will continue to need to be as we develop more and more partnerships with healthcare. Healthcare needs to know what are we signing on for, right? Everybody needs to know, what are you promising to deliver? And so for the past years, our work at the Food as Medicine Coalition, for about 4 years, we've been working on accreditation standards and process. So, and we can kind of skip ahead and just see, these are the basic tenets. It's a 2-day process. It's a long, I can tell you, this was a hard slide to create, because it's such a complicated process that we have to participate in order to maintain our accreditation. But the big buckets here is that there's clinical integrity, and they evaluate that. There's client experience, which gets evaluated, and meal quality, which gets evaluated. The most important thing for folks to know is that the meal quality includes very, very specific nutritional guidelines. So all of our menus have to follow the strict nutritional guidelines developed by registered dietitians, approved by FMIC, and then we have to provide all of that back up to them. Again, they require us to do real live work with registered dietitians with every client. That's one of the differentiators with a FMIC accredited organization that you can see. And then there's a prohibited list of ingredients. So we're not allowed to use any artificial coloring, any preservatives, trans fats, or ultra processed foods in any of our meals. We just simply can't give those to clients and maintain our accreditation standards. So other things that aren't on here, but they're really evaluating us on financial pieces, volunteer pieces, food safety, HIPAA requirements. We are, required to prove our HIPAA compliance. And so FMIC accreditation, when we worked on this and developed this as a community, we really wanted to be able to show potential healthcare partners, look at this very, very rigorous set of accreditation standards. This should be what you expect from a partner.
And when I think about, again, managed care, they're in the business of risk management, right? And so this accreditation makes me feel a lot more comfortable, like as a director, senior director, deploying a program, and it makes me feel a lot more comfortable that this is kind of regulated and monitored and follow certain standards than if I was just trying out a program that did not have this accreditation. Okay, and there's multiple participants in this, right, Leah? So who are the partners?
Sure. So first of all, you can see Open Arms obviously is located in Minnesota. The shaded yellow piece is where we can do where we can ship our meals in 2 days. So we have the ability to serve the entire Midwest if there are partners willing and interested in those kind of relationships. Other FMIC accredited partners are represented on this map. And so folks I know on the call might be in different states. There are many, and we're working to do, to accredit more all the time. So we have at FMIC, there's a rigorous list of programs that are in some sort of level of the process trying to get accreditation. So we're hoping to have an even bigger network, and so that folks know that there are partners out there who are really rigorous in their standards.
And from a national managed care perspective, I know a big concern is scalability, right? And so seeing this network, being able to see that there's different organizations that can fulfill in different markets is encouraging, right? If I was at Cigna, Aetna, if I'm looking for a partner that can do this in multiple markets, this definitely checks the box. One other big concern that an objective that I used to have to navigate was the conversation between non-for-profit providers and for-profit providers. And so I want to assure you that non-for-profit providers meet and exceed a lot of their SLAs. And so it's not, it's not about saying one model is always better. I would say that though, you do get a different level of personalization with this model with the dietitian. You get a different level of community trust and mission alignment with working with a non-for-profit than you would with a for-profit. And so again, a lot of that can drive member adherence to the actual intervention that is being deployed. So those are just some considerations. And I'm happy to talk to folks offline about kind of my experience around this as well. But this is meant to encourage you to consider non-for-profit providers of these type of services as equally as you would for-profits. And then one of the other big objections that I used to navigate was a lot to do with cost effectiveness and ROI for these services. So as part of the work that we've been doing with Leah, we actually have third-party actuarial review of Open Arms' data and pricing models, and have been able to solidify a very conservative, I would say, estimate of 15% ROI on the work and the meals that they deliver. The data was based in Medicare fee-for-service non-dual population, and so that's why I think it's incredibly conservative. And then the main cost drivers in the analysis really came out as hospital readmission reduction and skilled nursing facility admission reduction as a result of the work that Open Arms is doing, and then alongside ED visits and emergency transportation reduction being secondary. So those are some really big numbers. Again, in managed care, you have to be able to build the business case for why this makes sense and how can it move the needle on total cost of care and cost savings for your membership. So we definitely have that data and validation. Additionally, I would say current state Open Arms membership today includes predominantly Medicare folks, some Medicaid, and some from the VA as well. And most predominantly in the data that we looked, this is self-reported data from Open Arms patients and users. And so Aetna, Cigna, Blue Cross, Medica Health Partners really come out on top as the main carriers for those folks. And we'd love and welcome partnerships because we're already serving your members. And so it would just be another step in formalizing the relationship. And reporting was also another really big concern, right? As managed care, you need to not only set up the right infrastructure, but you need to be able to report and track outcomes. So Leah, I was hoping you can share a little bit about how you actually measure outcomes and what your reporting systems look like.
Sure. So partners that we work with, we offer, our healthcare partners the opportunity to select the group of clients that you want us to serve. And obviously you decide eligibility and then we own the rest of the process. And so we've done some exciting projects and pilot projects with different populations that folks really wanted to look at. And so sort of our newest opportunity was that postpartum group. And so that's a group that we've never served before, but we were approached and said, we've got these really high-risk pregnancies. Let's see what food as medicine can do to reduce preterm deliveries and high-risk pregnancies. And so the healthcare entity defined the population and we took over the rest. They defined the eligibility of the population, gave us some feedback on meals and the appropriate diet and things like that that they wanted to offer. And then, we do the rest. We have client services folks who collect data, and are able to report back to healthcare partners. We're keeping track of nutritional counseling and progress there, which we can report back to partners. And of course, we also deliver the meals as well. And so we can report back on missed deliveries and even some of the changes that happen during deliveries. And so one of the nice things is that when we're making contact with patients and delivering their meals, sometimes we hear things like, we're moving, we're going to be in the hospital, information that we can share back with partners, because I think a lot of times patients are a little more interested in sharing information if they know that their food is dependent on that, and that we've developed a relationship with them in a way that makes them more likely to come back to us and give information that plans and others might really depend on. So there's a number of ways I think that we can help with a better relationship for the plan or payer.
And speaking of data in particular and pregnancies, I remember struggling a lot because especially with pregnancy, there's a 3-month data lag when it comes to claims. And so when you have the boots on the ground that Open Arms does, and you have that relationship established with clients, you do get a lot more insight into changes in their health and how to better serve them and connect with them, so that it can be an absolutely critical component of meeting, exceeding quality goals and outcomes, and really delivering cost savings to the population. And speaking of reports, Leah, you surveyed your client population and you got some great results.
Yeah, we actually survey our client population twice a year. So, which is also something that we are willing to share information with our partners. So one time a year, we serve our clients really focused on their food needs and their meal needs and what they think of the food, what they're eating, and what they're not eating. How can we make changes that make things better and that. And then this really comes from the effectiveness survey, which we do once a year. And we get really incredible results. I think the most, impactful and are about retaining independence, living at home, helping folks follow the rest of the treatment that they might have for their illness. Obviously, staying out of the hospital is a huge one, and taking medication on time. These are things that can make immediate health differences. Again, some of the, just sort of to wrap it up, some of the differentiators for working with a partner, somebody like Open Arms would be the continuous registered dietitian involvement is a big one. Some of the things that we offer that other folks don't always offer is that we serve the whole household. I know Demi talked about this earlier. This really started for us back in 2006 when we started to serve folks who had breast cancer. And one of the things that we noticed was we would have this medically tailored meal that was, is appropriate for somebody who's going through treatment for breast cancer or some kind of cancer, but they would give the meals to their kids because very few moms, especially single moms or moms who are in crisis, are going to eat meals and be, in a situation where they might be food insecure and not give them to their children. So at that point, we added on dependents and caregivers as an option. And so we do provide meals for dependents and caregivers within the household, recognizing that most of the time the primary client just simply will not adhere to their diet without serving the rest of the folks in the household. So again, some of the things about fresh made food and being able to get fresh vegetables and fruit with your deliveries and some of the extras that we provide, I think really can help folks stay adherent to a special diet.
Yeah, and absolutely excited for partnerships with these are a lot of our partners, so we would love to have further conversations about how we can enhance their offerings and how we can partner better. Just to wrap it up, I do have to say, managed care organizations really don't need another food pilot. Again, we really need to start building that nutrition infrastructure. And again, for members that are struggling with both social determinants of health and clinical needs, looking for that solution or offering that solution that can do both and solve for both at the same time is critical. And so we would love to welcome any comments, questions, and also thank you all for joining the conversation today. But I would love to get any questions from the audience this time. Anybody brave enough? Curious what resonated, where you're seeing similar movements. All right, well, while we get a brief soul, I will mention that we will be sending out the deck. We'll also be sending out a checklist for managed care executives that they can use that as a way to screen vendors. So it's meant to, again, I've used those frameworks in my own work, the type of questions that I've had to ask so that I can build that internal business case. And so hopefully that's helpful. And then I'm happy to jump on calls with anybody that wants to go deeper into any of the topics that we covered today. And yeah, would love to encourage you to dig into the various policy proposals that we covered, dig into what different states are doing. And of course, if you're open and interested to partner, definitely grabbing time with Leah and or myself. We would love to have that conversation. Leah, anything else? Oh, okay, we got a question. Jennifer asked, can you talk more about a step-down approach? The next tier down of folks who are able to make meals but need help with the food ingredients.
Sure. I mean, I think, one of the things that was in the presentation was medically tailored grocery bags and food boxes. And that's something that Open Arms has done some of, and we have some great partners in the community and other folks in the community who are doing that. I think it's a brand new area, medically tailored groceries. There's literally no definition about what that actually means out there right now. But there are programs who are providing boxes of ingredients for folks who can cook for themselves and who need the ingredients, who need access. I think it works well for folks who need and don't have access to fresh fruits and vegetables, fresh proteins, things that are really difficult and expensive right now to get. And so those boxes and those medically tailored grocery bags work really well for them. We did do some of that with our high risk pregnancy group, especially our cultural groups, who really placed a high level of importance on being able to have everybody in the household eat out of one, meal, eat the same meal. And so we provided some of our East African clients with ingredients and things like that so that they could make healthy, very high protein, high calorie meals together and that are appropriate for somebody with a very high risk pregnancy. So I think they can work really well as those kinds of programs. And then I do think, yes, they can work as step down programs, something we've experimented a little bit here with, where if you can make some changes, if you can really have an impact in improving some of the health outcomes, the next stage for that client might be medically tailored groceries instead of medically tailored meals, right? They start with medically tailored meals, they get a little bit better. Now medically tailored groceries might be the next piece of that. And so I think this is a growing area that is exciting as we continue to develop.
I do want to say that I really appreciate Leah and everything that I've heard and through our work together, your willingness to just innovate and your be a true partner, right? Whatever the need is, really identifying that problem and then working around it to solve it. So thank you so much for your time and appreciate you sharing about Open Arms and all the great work you're doing. And thanks for everyone for joining us today. Again, don't be shy, reach out. We'd love to jump on a call with you, and good luck out there.